The question is Axitinib the new standard of care in second-line treatment of renal cell carcinoma? Well, Brian has given a very elegant talk, apart from that last slide, and there were lots of data in there, but I'm going to take the opposite approach and keep it very simple, because the issue is very simple. This is the case for the motion in a nutshell. The overall PFS in this setting with Axitinib is 6.7, and for Everolimus is 4.9. That's what the proponents would like you to believe. Now, many of the data I'm going to show have been shown, but they've been shown rapidly, so I'm going to take you through them more slowly. First of all, let's crack that nutshell. These data are not immediately comparable. They're certainly not directly comparable. The Axitinib versus sorafenib Axis study was a second-line study. The Everolimus versus placebo Record 1 study was not predominantly a second-line study. It was a much more heterogeneous population. So these are not capable of being compared head-to-head, and there are very different entry criteria, which Brian has already shown you. Oh, but wait, much of this benefit for Axitinib appears to be in the cytokine subgroup with a very impressive 12.1 months. Of course, there weren't any such patients in the Record 1. Now, in Europe, and this is a point for this audience, many patients in Europe do receive interferon first line, particularly in areas where sunitinib or pazopanib are not available, or not easily available. That applies to quite a lot of us. Now, if sunitinib and pazopanib are available, then they are used. So this cytokine question would require axitinib and interferon to be available and sunitinib and pazopanib not to be available. That does not apply anywhere in the world as far as I am aware. So this part of the argument simply does not apply. So the next part of the argument is, well, let's look in the setting that we are used to, post-sunitinib. And as you can see, in the Axis study, 4.8 months for Axitinib versus 3.4 for sorafenib, 3.9 for Everolimus versus the natural history of 1.8 for placebo. So a not very impressive, but probably clinically significant difference, if you were going to compare these studies, of 4.8 to 3.9 months PFS. But hold on. The post-sunitinib second-line subgroup, which is the actual group we are talking about, 4.8 months for Axitinib versus 3.4 months for sorafenib, 4.6 months for Everolimus versus placebo 1.8. So that is the real case for Axitinib to replace an established second-line treatment, Everolimus, 4.8 versus 4.6 months. That's 0.2 months, 6 days, or 144 hours, if you like large numbers. Are you really going to replace an established standard of care, Everolimus, because of a PFS difference of 6 days shown across two very different studies with very different entry criteria? Of course you won't. Now, I'm not standing here to say Axitinib is not a good drug. It is, I think, a very exciting drug, and I'm going to address that just briefly. So as you know, Axitinib is one of a few highly specific, highly potent, second-generation tyrosine kinase inhibitors targeted against VEGF and associated receptors. So how do we best use it? Well, the first thing is we must use it carefully. It can cause some very spectacular rises in blood pressure. This is a patient who, as you can see, has developed some posterior leukoencephalopathy, luckily fully reversible in him, but it does need to be used carefully, and we will be doing that. In fact, it's such a good drug that here are some phase 2 data just to show you that those phase 3 data that we've been talking about so far is not a flash in the pan. Phase 2 data, I forget the authors now, but I expect I could remember if suitably stimulated. PFS of 15.7 months, overall response rate of 44%, and a well-tolerated second-generation agent, predominantly hypertension being the problem, which we can control. So this is very good to use in the first-line setting. We must get the most out of these agents for our patients, not just slot them in where we feel they're most conveniently slotted. And indeed, Pfizer itself, which makes this drug, has come to this conclusion. And here is a study which is currently going on, comparing Axitinib with Sorafenib for treatment-naive or patients with one prior therapy. And indeed, I believe there will be some interesting data on Axitinib first line at ASCO in just a few weeks' time. So, if we now say that Axitinib is probably heading for the first-line setting in due course, and there's no strong reason to use Axitinib versus Everolimus in the second-line setting, where should we use Everolimus? Well, the subgroup analysis of 1 versus 2 prior VEGFR TKIs has shown that with 1 prior TKI, the PFS is 5.4, and with 2 prior TKIs, the PFS is 4.0. It's not a massive difference, but patients are interested not in hazard ratios, but in how long their disease is going to be controlled. And the authors of this paper summarized their results as supporting the use of Everolimus as the standard of care in patients who fail initial VEGFR TKI. That's not just my opinion, that's the author's peer-reviewed opinion. Let's look ahead then. The resensitization argument you've heard discussed, both by Brian and previously by Victor Grunwald. There are anecdotal and sort of small series reports, and it does look as if there is possibly a real phenomenon here. We might be able to get further data from further sub-analyses of Axis and Record. So we think it's a real phenomenon. We're not 100% sure, and we think it might be related to treatment-free interval between end of first TKI and beginning of second TKI. Now, if that were true, you would want to prolong that interval between first and second TKI as far as you could. With placebo, you're going to manage that for about 1.8 months. With Everolimus, you're going to manage that for 4.6 months. The point I'm trying to get across is that we're trying to get the most out of each line of therapy for our patients. And I'm saying that using Axitinib first line and Everolimus second line is our current best way to do that, if the data coming out at ASCO in just a few weeks' time are promising. So I think we should retain Everolimus for 3 hard reasons in the second-line setting. First, there are no data supporting any change of standard practice. 4.8 versus 4.6 months, clinically meaningless, statistically meaningless. Axitinib should be used to best effect. Now, I think you could argue, how do we use these potent, highly specific second-generation agents to best effect? But I'm pretty sure we shouldn't fritter away these very good agents in the second-line setting. Similarly, Everolimus should be used to best effect, and it works better after 1 VEGFR TKI rather than 2. We have a duty to give our patients the best chance to benefit from all lines of treatment. So on the 5th of May, you should vote against the motion. Is Axitinib the new second-line standard of care for renal cell carcinoma? No, it isn't. Thank you.